The presentation topic will be thermal ablation for autonomously functioning thyroid nodules. Dr. Negro, please.
Morning to everyone. Thank you, Roberto, for having invited me. In the next few minutes, I will talk about the use of thermal treatments in autonomously functioning nodules. Toxic adenoma is a monoclonal autonomously functioning thyroid nodule that produces supraphysiological amounts of thyroid hormones, and then the result is a suppression of TSH. As you see from the scan, the function of the surrounding normal thyroid tissue is also suppressed. The prevalence of toxic adenoma is between 1 and 10%. In areas where there is a iodine deficiency, toxic adenoma are more frequent. The annual risk progression towards hyperthyroidism is estimated to be 4% per year. It is more frequent in female than male, and it is more frequent in older people, older than 60 years above all. And the nodule become toxic, so the patient become hyperthyroid, usually when the nodule is above 30 millimeters. So the larger is the nodule, the more is the chance of developing hyperthyroidism. The traditional treatment options for toxic adenoma are obviously surgery. The disadvantage is the inpatient setting. There's the risk of consequent hypothyroidism. There's a scar in the neck, surgical complication, although infrequent. But the advantage is that surgical treatment is a definitive treatment for toxic adenoma. The other treatment option is radioactive treatment. Again, there's the chance of developing hypothyroidism. Radioactive treatment should not be used during pregnancy. As the advantage of outpatient setting, it is a definitive treatment and it induces a reduction in the volume of the nodule. And also antithyroid drugs that anyway have some side effects. This is not a definitive treatment because the nodule is autonomous, so it is not definitely cured by antithyroid drugs. You should not use antithyroid drugs during pregnancy because there are some concern in their use, and you can temporarily control the hyperthyroidism with this treatment. So the reason why you can think to use thermal ablation in toxic adenoma is that with thermal ablation you can induce a physical ablation of the hyperfunctioning nodule and you induce a reduction of the volume of the nodule. So in this slide that is it's not mine, is taken from a published paper last year, you can see on the left the nodule and on the right the ablated area. So obviously the larger is the necrosis area within the nodule, and the smaller is the autonomously functioning tissue that is left untreated. So the larger is the area of necrosis, the higher is the option, is the chance that TSH will increase. Then going to the clinical studies that have been published in the last 10 years, I will start with this randomized trial that was published in 2007 by Dossing and Laszlo Egedus. It is one of the few randomized studies that compare a single session of laser treatment with a standard treatment that obviously is radioiodine. So the authors enrolled 29 autonomously functioning nodules. They divided patients into two groups, one treated with laser and the other one with radioactive treatment. And the baseline characteristic of the patient were similar. The TSH was suppressed, and 6 months after radioactive treatment, the TSH was 1.2, whereas in the laser group, the TSH was towards the lower limit, was 0.32. So there was a difference in the rate of normalized TSH. And in fact, radioactive treatment achieved euthyroidism in 100% of cases, but of these patients, 13% developed hypothyroidism, and euthyroidism was achieved just in 50% of laser-treated patients. The baseline volume was similar, and the reduction of the nodule was similar in both groups, about 45%. Just to underline that the patient treated with laser ablation received an energy that now is considered quite low, that was 220 joules per milliliters. And you've seen yesterday from the lecture of Jill Roos that this amount of energy is considered too low to treat efficaciously the thyroid nodule. And this is a Korean study that instead used radiofrequency ablation in toxic adenoma. It is a multicenter study that recruited 44 patients. The authors used more than one single session, from 1 to 6. So the mean of number of the treatment was 1.8, and the mean follow-up of the study was 20 months. At baseline, the mean volume was 18.5 ml. The TSH was low, 1.1. The vascular grade was 3.1 in a scale from 0 to 4, and all the nodules were hot at scan. At follow-up, the mean volume reduced from 18 to 4.5. The TSH normalized from 0.1 to 1.2. The vascular grade was significantly reduced from 3.1 to 0.9, and 35 out of 44 of these hot nodules became cold or normal at the scan. And you also can see that as the nodule of the volume of the nodule reduced, then the symptoms and the cosmetic score clearly ameliorated. In the same study, the authors evaluated also the complication associated with the use of radiofrequency, and all patients complained of various degrees of pain and of sensation of heat in the neck, radiation to their head, shoulders, teeth, back, and chest, but they did not observe no major complications such as voice change, skin burning, or damage to the vital structure. The next study is an Italian study that is important because this study again used just one single session of radiofrequency, but this study divided patients on the base of the baseline volume. The authors recruited 29 patients. It is a retrospective study treated with a single session of radiofrequency, and the authors divided patients on the base of the starting volume. So group A, small nodules, less than 12 ml. Group B, larger nodules, larger than 12 ml. And this is the result of the TSH. And you see that in the group of small nodules, the TSH increased more than in the group of large nodules. In other words, it means that one single session of radiofrequency induces a normalization of TSH in a larger number of patients in respect to those who have a larger nodule. And in this other study by Gambelunga that was published last year, instead he used laser ablation again for toxic nodule, and this study had a 3 years follow-up result. It is a retrospective study, 82 patients, a single session of laser ablation, and the mean baseline volume was 12 ml. The volume reduction rate was 58%, and you see that again, nodules were divided depending on the baseline volume. The authors evaluated the rate of patient who can stop methimazole. So in other words, the rate of patients who were cured by laser ablation. And in 100% of patients with a baseline volume less than 5 ml, they could stop definitely methimazole. This rate was 19% in nodule comprised between 5 and 15 ml, 60% in nodule comprised between 15 and 25, but just 28% of patients stopped methimazole when nodules were more than 25 ml. So obviously the conclusion is that if the nodule is small, it can be completely ablated by laser or radiofrequency. If the nodule is large, it's more difficult to ablate all the nodule, so there's an untreated part that continue to produce an amount of thyroid hormones that keep the patient in a state of at least subclinical hyperthyroidism. And this is another study that was published quite recently, and this is a comparison between radioactive treatment and a single session of radiofrequency. The authors recruited 50 patients with toxic adenoma, and again, they divided patients into two groups, one treated with radiofrequency and the other one treated with radioactive treatment. The baseline TSH was similar, was quite low, and the baseline volume was not different, 11 ml for radioactive and 14 for radiofrequency. The volume reduction was similar in both groups, about 17%. The rate of patients who became euthyroid was 17% in radioactive treatment and 90% in radiofrequency group. No one had the persistence of hyperthyroidism, and 8% and 9% developed subclinical hypothyroidism. But the difference between one group and another was that in radioactive treatment group, the rate of hypothyroidism was 20%, whereas in the radiofrequency group, no patient developed hypothyroidism. And then the authors stated that using radiofrequency treatment, the patient had no radiation exposure and obtained a lower risk of developing hypothyroidism. So they suggest the use of thermal ablation in particular condition, especially before pregnancy, before a pregnancy is planned, because if you use radioactive treatment, you should delay pregnancy for at least 6 months. You can consider thermal ablation after pregnancy, for example, when the woman is breastfeeding, and also during pregnancy. Anyway, you should remember that you have to use a bipolar electrode and not a ground pad to avoid that the current electricity spread through the body and then the fetus. Another step forward was became from this other Italian study. And this study is important because it is the first study that combined thermal treatment with radioactive treatment. And this combination was used for large toxic adenoma. The study was by Chianelli and Enrico Papini. It was published 5 years ago. They recruited 32 patients with a single or dominant hyperfunctioning nodule. They divided patients into two groups. 15 patients were treated with laser ablation, and 1 month after laser ablation, they administered radioactive treatment. In the other group, they just administered radioactive treatment. And what you see is that the baseline volume was similar, about 28 milliliters in both groups. At 12 months, the reduction of the volume was 15 in the radioactive treatment and 10 in the combination treatment. At 24 months, the volume of nodules treated just with radioactive therapy was 15, so was stable. And the volume in the combination treatment, radioactive and radiofrequency, was 10 ml. So the combination treatment obtained a stable but a further reduction of volume in respect to radioactive treatment alone. And the other result was that, again, the baseline TSH was suppressed in both groups, and both groups obtained an increase of TSH. So patient recovered from hyperthyroidism and became euthyroid. But the difference was that in those pre-treated with laser ablation, the calculated dose of radioactive was 480, that was lower to the calculated and administered dose of treated patient just with radioactive treatment that was more than 600. And so the conclusion of the study was that if you treat patient at first with laser and then with radioactive therapy, you can obtain a greater reduction of the nodule volume, and then you can administer a lower amount of radioactive dose. After the study, we published another study that is important because it is the first study that is a head-to-head study versus surgery. And Mario Stan alluded to this point because thermal treatment confront to surgery. So the point is that we have to make an evaluation when we talk about thermal treatment, and we have to evaluate if this treatment can compete with surgery. And then in this study, again, we enrolled just patients with large toxic adenoma. We enrolled 27 patients. The baseline volume should exceed 20 ml, and the calculated therapeutic activity of radioiodine should exceed 600 megabecquerel. That is the amount that is allowed to give in Italy as in outpatient setting. So these kind of patients are patients that typically are referred to surgery. And then the patients were divided into groups: one laser ablation plus radioactive treatment at a fixed dose of 555 megabecquerel, and 13 patients underwent surgery. The baseline characteristic was similar in both groups. The ratio male-female was similar. The age was similar, about 60 years old. The ratio uni-multinodular goiter was similar. The TSH was suppressed, and all the patients were thyrotoxic. So the mean FT4 was 2.7. Thyroglobulin was increased, and the nodule volume was, as a mean, 31 milliliters. What we obtained with the combination treatment was that at baseline the volume was 31. 6 months after laser ablation, we obtained a reduction by 40%. And then 6 months after radioactive treatment, the reduction of the volume was 70%. So we obtained a significant reduction of these large nodules. And we obtained, in respect to surgery, a similar rate of subclinical hypothyroidism and a similar improvement in health-related quality of life. So the conclusion was that the study shows for the first time that combination treatment of laser and radioactive treatment is a competitive alternative to surgery because it solves definitely the problem of a large toxic adenoma. This is just an image of the nodule. You can see the nodule that has a baseline volume of 37 ml. The scan that demonstrates that the nodule is hot, and at the end of the combination treatment, the nodule volume was 7.5 ml. As a conclusion, thermal therapy in autonomously functioning nodules, they are a viable option in patients who refuse radioactive treatment or when it is contraindicated, in patients who refuse surgery or when it is contraindicated, but it may be indicated in small nodules smaller than 10 ml because it is curative with just one session of laser or radioactive treatment. It can be considered in medium nodules between 10 and 25, but in this case, you should consider 2 sessions or a combination treatment because it is possible that just 1 session is not curative. And in large nodules, it is an alternative to surgery when you use thermal treatment in combination with radioactive treatment. Thank you for your attention.
Thank you. He presented very nicely how to manage AFTN by combination of thermal ablation, surgery, and iodine therapy. Are there any questions or comments from the floor?
So I was thinking in United States, we use surgery and iodine-131 treatment. Surgery or iodine-131 treatment for autonomous nodule. But there is plenty of literature in alcohol injections of the autonomous nodule. But now we have faded away the use of that. Nevertheless, it's very efficacious. In Italy, are they still using alcohol or they abandoned that treatment?
No, ethanol ablation was used in the past for autonomously functioning nodules, but this is not a definite cure because the hyperthyroidism recur. And the other problem, as you know, is that the injection of alcohol-induced adhesion, so it's a problem for surgery. But ethanol ablation is not considered anymore a therapeutic option for autonomously functioning nodules, not at all.
Papa Vergis, endocrinologist from Greece. I wonder, we have comparison between radiofrequency and radioactive iodine, laser ablation, radioactive iodine. I don't know if there is any study between laser ablation and radiofrequency.
No, to the best of my knowledge, there is no study that compared these 2 techniques in autonomously functioning nodule. Although I don't think that we expect to find any great difference between these 2 techniques, at least in these kind of nodules.
What will be the...
I mean that the critical point in treating with thermal ablation and autonomously functioning nodule is the baseline volume and then the ability of the operator to ablate all the nodule. So the problem is that if the nodule is very large, it is possible that you leave an untreated part of the nodule. So as it is an autonomously functioning nodules, it means that the cell that compose the nodule are a monoclonal cell which have a constitutional mutation of the TSH receptor. So if you leave one cell, it will replicate and then the hyperthyroidism will recur. This is the problem.
Thank you. Thank you, Roberto, for your presentation. It was really thorough and comprehensive. My objection is that laser ablation and RFA are not the same. In the sense that with the laser, more tissue, as far as I experimented both techniques for a long time, the laser ablation may leave behind more tissue than RFA ablation. And the second point is that patients do not want to have any radioiodine. It's not the point to have less radioiodine, but the point is to have or do not have any radioiodine. So I don't. My criticism is that a mixed technique would not be agreed by most patients.
About your first question, regarding the comparison between laser and radiofrequency, my opinion, given that there's no study that compared in these hot nodules one technique with another technique, my personal experience is that usually hot nodules are spongiform. I mean that usually they have some small cystic areas within the nodule. It is very rare that hot nodules are solid and compact. Usually they are more a composition of spongiform nodules than solid. That is the reason why, in my opinion, laser anyway works well because of the composition of the hot nodules. The second point, I agree partially. I mean that my feeling is that the fact that the patient refuse radioactive treatment, I don't want that this is used as an excuse to treat the patient with thermal ablation. I mean that when we have the patient in front of us, we should explain pros and cons of each treatment option. I would not like that we use the refuse of the patient for radioactive treatment as an excuse to treat patients who have not the indication to be treated with thermal ablation.
Thank you. I have one open question. Any doctor has experience with both laser and RF ablation? Nobody? Sorry, nobody.
Thank you.
My comment, sorry, my comment, last comment, short comment is, in my opinion, in terms of the size of AFTN, Korea or Asian nodule seems to be smaller than Europe or other countries because I treated many AFTNs, but more than 20 milliliter is very rare.
More than 20 is?
20 milliliter is very rare.
Oh yes.
So maybe it seems to be different. Thank you.
So the mean baseline volume, you mean that in
Yeah,
Asia or Far
maybe
East
different,
is
yeah.
smaller than in Europe?
Yeah. So no other questions or comments? If no, we will close this session. Thank you
you.
for the speakers and the participants. Thank you.